Good evening, everyone. My name is David Pearson. I'm coming to you from the Mayo Clinic in Phoenix, Arizona. Thank you so much for joining us this evening. We have a great lineup of some very interesting cases to talk about. This, as you know, is the American Hernia Society webinar for the Ventral Hernia Masterclass. I'm going to go ahead and pass it over to Bola. He's going to introduce our first speaker. But this session is meant to be interesting, and we're going to keep an eye on any comments or questions that come up in the chat, and we'll try to share those with the whole group and try to answer any questions and have our presenters answer questions for anybody that may have them. So with that, Bola, do you want to get us kicked off?
Bola Ladibami, University Medical Center. First presenter will be Dr. Mead and her resident, Dr. Knight. Dr. Brittany Mead is a graduate of general surgery residency program at Ross University. She subsequently went on to complete a fellowship in minimally invasive surgery at the Carolinas Medical Center. She's currently the assistant professor at the Department of Surgery at Rush University, with her primary focus being abdominal wall reconstruction. Dr. Mead.
Hi, everybody. Thanks, Bola, for that introduction. As he said, I just finished my fellowship at Carolinas Medical Center. Was very happy to have spent a year with Dr. Henneford and Dr. Augenstein out there doing abdominal wall reconstruction, and am now starting a program here at Rush University Medical Center, and had a complex patient who'd had multiple hernia surgeries and a mesh fistula come into clinic that I had the opportunity to operate on, and Dr. Knight will be presenting this case. In full disclosure, the resident who did the case with me was not available, so he's graciously offered to present this, but he was not in the case, so he's going to do his best. So I'm going to see that. All right,
yes.
Thank you. Go ahead.
Great. Yeah, thank you for the introduction, Dr. Mead. I'll be presenting this case on behalf of her, as well as the surgical resident who did that. I'm a PGY3 currently at Rush University Medical Center. So thank you for allowing me to present this case to you guys. So for Our Lady, she was a very nice 74-year-old female who had presented to our office with obvious history of multiple hernia repairs. Past medical history included she was a non-diabetic, BMI of 23, non-smoker. As we can see from her past surgical history, her hernia surgery dated back to August of 2000. From these old op notes, there was a clear cycle of complications where every time there was a hernia operation, it just recurred worse than it did the first time. From the op notes, we saw that the biggest mesh that was used in these surgeries was a 6.6 centimeter mesh, so pretty insufficient coverage for most of these hernia repairs. In the op notes, it was also fairly unclear whether there was retrorectus, onlay, other forms of hernia repair, but it was reassuring that we did see no details of component separations or cutting of the muscle. Just to continue, for her past social, non-smoker, family history was non-contributory, and she was not on any blood thinners at the time. So for exam, this patient with multiple surgeries, she had a chronic wound at the superior aspect of her incision and a large M1 hernia in the M1 distribution. This can obviously make things more difficult for Botox, and we'll explain that later. She was currently seeing someone at a wound care clinic and regularly applying collagen-based products. So we got a CT scan for which you can see here. It does show a fairly large 11 centimeter defect. We can see tacks as well as multiple fluid collections superiorly, as well as the bowel in there as well as other fluid collections that you can see associated with bowel, as well as the abdominal wall. And there seems to be what you can see is a line of mesh, and this is where we were concerned for this chronic wound, as well as a mesh fistula.
In this area.
It's right up there. Yeah. So for some pre-op considerations for this patient, for a patient coming to us for the first time, she was fairly optimized for surgery, given the fact that she was a non-diabetic, non-smoker, BMI less than 35. This is a fairly fair rarity when presenting to you for the first time. Some things that we wanted to think about was Botox. Again, as I mentioned earlier, this hernia was in the M1 distribution. Kind of given that location, Botox doesn't usually work as well. Usually like to see it more so in the M3 distribution. Then we needed to think about what mesh type were we going to use for this repair. This was likely going to be a contaminated case, given the chronic wound. So when I discuss a paper later in this presentation, we kind of decided based on the low risk, high reward of using a biologic mesh compared to a synthetic mesh. And then for any of these larger hernias, cosmesis is always something that we have to consider. Will this patient need a skin incision, talar tacking, paniculectomy? There was a little bit of redundancy in the epigastric region. However, this patient did not want a formal paniculectomy, so this was deferred at the time of operation. So for our surgery, a midline incision was made. Once we entered the abdomen, we did see two old meshes were encountered. They were all 3-6 centimeter or so patches, two onlay, one most superiorly, which was associated with the fluid collection and wound, and then one mesh that was intraperitoneal. The culture of the fluid was sent, as well as the associated mesh from the wound. This actually ended up growing nothing. We also, at the time, removed the foreign bodies, including at the bottom permanent sutures, metal tacks, and then we then proceeded with pre-peritoneal ventral hernia repair. After that, we placed 30 by 30 stratus mesh, pigskin mesh, in a diamond configuration. Dr. Mead likes this because of the coverage that it gives, with the hypotenuse being larger, longer than the actual size. So we then proceeded with talar tacking, excision of the skin, and we were able to keep the belly button intact, which the patient was very happy about. And then at the end, we placed staples as well as a Provena wound vac. We've seen a lot of decreased skin and soft tissue infection rate with placing these Provena wound vacs. And a transfascial drain was, I forgot to say, was placed as well. So for post-op course, the transfascial drain and Provena wound vac were removed prior to discharge on post-op day 4. The sub-Q drain and staples were removed in clinic on post-op day 14. And the patient has been doing very well post-operatively, and we'll see her again in 3 months. So, as I had mentioned earlier, when deciding on a mesh, we like to look at the literature to help guide some of our decision making. So, what is the best mesh choice in contaminated fields? There is a good amount of literature out there. You could kind of find whatever you would like to fit your decision making. But from this paper, we saw that, kind of based on comparing biologic mesh versus permanent mesh in a contaminated field, the recurrence rates were fairly similar. However, maybe slightly higher with the biologics, but again, this was not a significant difference. However, the risk of readmission with mesh infection, excisions, goes up significantly with synthetic mesh placement. So for us, we were more comfortable with a biologic because, again, this lower risk, higher reward overall. And that's that patient.
Thank you, Dr. Knight, for the great presentation. You did a very good job with the presentation. I see we already have a couple of questions in the chat group, and please keep putting your questions there. I'll probably fire the first salvo to Dr. Mead and Dr. Knight. And can you just walk us through your algorithm between maybe doing 1-stage versus 2-stage repairs? And also with the mesh selection, I know you guys use biologics, but how does bioresorbables fit into this space?
Yeah, so my algorithm for deciding between a 1-stage and a 2-stage procedure is really how how contaminated of a case are we talking about? If, for example, we were seeing pus coming out of this chronic wound, and I was expecting, contamination of the bowel, etc., I would close primarily, preferentially, and probably not place any mesh at all. But given that this fluid that was around the mesh had already been sampled and was sterile at the time, I thought it was very reasonable to place a biologic mesh. I think there are some people who would, have felt comfortable placing a synthetic mesh in that case. But I just, would feel more, based on my treatment practice and the way I trained, I think I felt more comfortable with the biologic. And then where does biosynthetic come into the algorithm? My limited experience with biosynthetics has primarily been kind of negative, in the sense that we often see really severe complications with things like phasics mesh. And I'm not sure if it's because the body chemistry changes when phasics mesh gets infected, and so it doesn't absorb the way that it's supposed to absorb, and it ends up getting excised in the end anyway. But it's just not something that I have used very regularly. And so for these contaminated meshes, or contaminated cases, I generally prefer a biologic.
Thank you, Dr. Mead. You have a lot of questions coming your way. The next question is from Dr. Sacco. She asked about your antibiotic management for this patient.
Yeah, so because this was sterile, I did not do any antibiotics preoperatively. She had no white count, and she had this chronic infection and fluid collection for a long time. So I didn't do anything other than a dose of Ancef prior to surgery, and then after the surgery, she got 4 days of Ancef, and that was it. And then the cultures grew nothing, so I didn't feel that there was any need to proceed with any additional antibiotics.
Does anybody do anything differently on the moderators or on the panel, just out of curiosity?
I don't rely on culture data for these cases. We've actually looked at this, and it's very dependent on where you're sending it, how they're sending it. Sometimes these specimens are sitting out for too long and won't, appropriately collected. I'm pretty proactive about empiric coverage. If I have any old culture data, I'll use that to guide extended coverage with antibiotics. We've retrospectively reviewed and had good outcomes, but again, we're very aggressive about antibiotics here at OHSU. It might also be because my single stage procedures, oftentimes I was using a permanent synthetic and not a biologic, so that might impact my decision making.
Yeah, I usually do antibiotics 2 weeks before and 2 weeks after. I know it's been looked at a little bit, but I agree you can probably find something in the literature to support it and something to not support it. So I was just curious what other people are doing.
Dr. Yuso asks, what are your thoughts on closing skin versus delayed primary closure in addition to placing the wound vac? Practically, do you do delayed primary closure in some of this patient population?
Yeah, that's something that we did regularly for these contaminated cases at Carolinas, and I think we had great outcomes with that. For this patient, I excised the whole, mesh fistula, the fistula, the fluid collection, as well as the skin that was surrounded it. And so I put her back together loosely with staples and put a Prevena over it, and fortunately she did okay. But doing a delayed primary closure is something that I'm always thinking about for these cases.
Dr. Vaughn, you said you use synthetic mesh for your one-stage closures. Have you tried all bioresorbables for this one-stage closures also? And what has been your experience so far?
Yeah, so again, historically, I was using a lot of macroporous polypropylene. I've become more enthusiastic about trying bioresorbables like P4HB, as well as biologics with good outcomes. I can say that retrospective review of our data here at OHSU with now over 800 cases in 4 years for our group, we've had equivalent outcomes across the board with regard to skin and soft tissue infections, short-term complications and long-term issues, recurrence rates less than 5% among all cohorts. So I've kind of become more accepting of the options. For something like this with an M1 component, which I classify as a atypical, I will typically use a permanent synthetic.
Dr. Artem, I apologize. I have a hard last name like you do, so I don't want to butcher it. Was asking how challenging was it to close the M1 fascial defect, Dr. Mead?
It was challenging. She was on the tighter side, but I did have to raise some skin and soft tissue flaps in order to excise that kind of mesh fistula and the onlay meshes that were there. And so once I had done that, it came together nicely. So I didn't feel like it was on too much tension, but it wasn't easy, and it did require some tissue mobilization.
Any more questions from the?
Just wanted to piggyback to what Dr. Ayuso mentioned regarding incisional vac versus Provena to improve lymphatic drainage and microcirculation. So, we tried several times. I remember even from residency, this so-called French fries technique. I'm sure you guys, use it as well. When you basically do like every inch deep dermal, to a PDS or something like that, and then just use black sponge. French fries essentially going all the way to the fascial level and just sticking between those 1 inch apart deep dermals, and then you put Provena on top of that. So you keep it for 6 days, take Provena off, pull those French fries out, and then you can put a new Provena on if you want. Actually, it's pretty nice. I think in our experience was good result with intraprostatic fistulas.
Yeah, I'm a big French fry fan. If I can't decide if that I want to do a DPC, if it's a grossly contaminated, there's stool spillage, there's pus, like I'm doing a DPC. But if it's like, I'm not sure I really need to take this patient back to the OR, I think it works pretty well.
That's
So
interesting.
Dr. Sacco, I think if the patient is pretty sick, it might not be able to take another hit, then I French fry. But if it's a patient that is pretty stable with a lot of contamination, I'm also a big fan of DPCs from fellowship.
For those of you that are using Provena, are you, or I guess, are you placing subcutaneous drains as well, or are you exclusively relying on Provena?
So I place sub-Q drains. The sub-Q drains, if you're doing a French fry vac, they won't do anything while the
Right.
French fries are there. But once you remove the French fries and then you put the Provena on, because what I'll do is I'll usually do 3 or 4 days, then I'll
Mhm.
remove the French fries and then I'll put a Provena on for like 7 more days.
Yeah.
So the drains will do something once the French fries are gone. So you just have to make sure that your team knows, like, please don't pull the drains even though they have 0. They will start working later, but I still leave them, the sub-Q drains always.
Yeah, I just aggressively will drain sub-Q with like usually 2 drains in these circumstances, and then do a Provena with a subcuticular closure. But
Yeah,
clearly,
so
a lot of good ways to do it. I think just drainage in some form is critical.
Yeah. We did obviously sub-Q drains, and then we closed with interrupted 2O monocryls and then stables on top of that in Provena.
just to finish that thought, I have modified from doing staples to using the full Stratafix and putting Provena over that, and patients have done pretty well with the DPCs. We have more questions in the chat. Dr. Adam asks, how is the mesh fixated this time?
The mesh is fixated in the cardinal directions. I generally do fixate the inferiorly to the pubic bone, and then superiorly and laterally. Transfascial, interrupted PDS.
I think we've had a robust conversation. We're going to pivot to our next presentation. David Pearson.
Yes, thank you for your comments so far. We're going to go ahead and move on to our second presentation. This is coming from Dr. Lin. Dr. John Lin is a graduate of general surgery residency training program at Northwestern University. He subsequently went on to complete his fellowship in minimally invasive surgery at The Ohio State University and has been on faculty at North Shore Endeavor Health since completion of his fellowship in 2011. Dr. Lin's clinical practice is focused primarily on abdominal wall reconstruction and bariatric surgery. He is also a clinical associate professor at the University of Chicago. And here we have Dr. Lin. Do you mind presenting Dr. Ayuso for us?
Yeah, thank you. And sorry, I'm in an Uber driven by a teenager, so sorry about my background. So Dr. Celia Ayuso is currently our fellow in minimally invasive surgery at Endeavor Health. We were very fortunate to recruit him from the Atrium Carolinas Medical Center program, where he came with a tremendous amount of knowledge, particularly in open abdominal wall reconstruction. And we have learned probably more from him than any of our fellows in the past, which says a lot. We've had some outstanding people before. Sully's going to be taking a faculty position in Texas after this year. We're very, very happy and very proud for him. But paired with our discussions about management of perioperative comorbidities, particularly obesity, Sully's going to be talking about some novel strategies to address that.
Yeah, thanks so much, guys. I appreciate you allowing Dr. Lin and I to contribute to the talk tonight. Before we start, I just want to say that the focus of this presentation will be more so on the preoperative optimization of the patient rather than the technical details of the surgery from an abdominal wall reconstruction standpoint, which have not yet happened. So we'll dive in. So one of the neat parts about the fellowship here is we have a fellow-run clinic with staff support, obviously. But we had this guy who's a 42-year-old who presented to the fellow clinic for evaluation of both surgical weight loss and then a symptomatic ventral hernia. So his BMI was 46 at the time of presentation. He was a non-smoker, was not diabetic. Medical history only significant for prediabetes. His A1C was below 6. His surgical history, he had an open appendectomy in his 20s in Mexico, and his postoperative course was complicated by a fascial dehiscence and subsequent open abdomen. He had multiple takebacks and then developed a hernia that's enlarged over time. He has some thinning of the skin, as you'll see in the following picture, and then loss of domain, however that's defined. He's not having any obstructive symptoms, hasn't been hospitalized in relation to his hernia, but it is impairing his movement limitations pretty significantly and impacting his quality of life. So this is a picture when he presented to clinic. The axial CT scan is from about 6 months ago, but you see rectus muscles retracted and the width of the defect's approximately 12 centimeters. So traditionally, tools in the armamentarium from a weight loss perspective prior to abdominal wall reconstruction, we have lifestyle, so things like exercise and dietary modification. In this guy's case, he has pretty significant arthritis, has not been able to lose weight, and his movement is pretty significantly impacted. So we're limited to what we can do from that standpoint. And then medications, I think this is going to be a really big talking point in the discussion. I know a few of our moderators have actually contributed to literature on this topic, but things like GLP-1s and fast tracking patients to the operating room and getting their weight down. And then surgery. So, depending on where you're at, potential to refer to bariatric surgeons for a sleeve gastrectomy. Most often, some people will do bypasses, but obviously you're at risk for doing an anastomosis in the setting of a large hernia in terms of obstruction and the problems that could result from that. And so I think the neat part about kind of what we do here is we do a lot of endoscopy. And so I think that we're starting to kind of blend these things in terms of, how we think about optimizing patients. So, first, before I delve into kind of the endoscopic options for this patient in terms of losing weight, why does it matter that we get the weight down on this patient? We know with weight loss prior to big abdominal wall surgery like this that we will be more likely to close the fascia and then, obviously decrease wound morbidity, which will therefore decrease recurrence. And I think, one of the things that we looked at recently from the group in North Carolina is, what is the long-term sustainability of these prehabilitation efforts? Is it a teaching moment before a big hernia surgery to get these people on the right track so that they continue to have good habits and lose weight and have smoking cessation, et cetera. And what we found looking at that is indeed, these are the things that potentially matter most to our patients when you're looking about long-term health and longevity. So a few things to just kind of review. So prehabilitation, I think, is one of the hottest topics in hernia right now, because there are so many different opinions on, when to operate on people, cutoffs, thresholds for taking patients to the operating room. I think these are really good discussions that are kind of push the needle back in the direction of, maybe not being as stringent with prehabilitation efforts. But at the same time, recognizing that certain things are important for certain patients, right? And I think neglecting these prehabilitation efforts in their entirety is potentially doing disservice to a patient, especially when it can alter the type of operation you're doing and the long-term outcome. And so management of abdominal wall hernias in patients with, severe obesity, this is a complex problem. There's no real consensus on here. Typically, at least at our institution at North Shore and Endeavor, the practice would be to do a sleeve if we intervene surgically prior to doing a big hernia repair. And then this last paper is an interesting paper that Dr. Lin brought to my attention not too long ago, from the group at UCSD, looking at the use of GLPs and reducing people's weight and BMI. And what their group found is actually they were getting patients to, the operating room much more quickly than they would with just a lifestyle modification standpoint only. So in this particular study, they had a BMI cutoff, which I believe was around 33. And they, looked at patients that did and did not have GLP-1s included in their plan of care. And they were getting people to the operating room with significant weight loss in about 6 to 7 months, which is pretty impressive. And I'll talk about how that compares to, the weight loss and the weight loss trajectory for endoscopic sleeve procedure. So the procedure that we're planning for this patient, we're actually going to be doing on Friday, is an endoscopic sleeve gastroplasty, which, has been around for over a decade. We've been doing it, some version of it at North Shore since 2008. But it's gained in popularity, and mostly since there has been, randomized data. The Merit trial was published in the Lancet a few years ago looking at, outcomes. And what they found there is that the expected, excess weight loss is approximately 50% of these patients, and most of that weight loss occurs within the first 6 months. The other options for endoscopic therapies, intragastric balloon, the FDA approval in the United States is that you actually have to take the balloon out at 6 months, and so long-term weight loss effects are obviously not as sustained. At least that's what we found when compared to the ESG procedure. And so this is the study that I was just referencing, and I think it's going to be neat because Dr. Ujiki and the group here are getting, are going to be partly responsible for tracking these patients out longer term and kind of seeing, what weight loss looks like and from a more long-term setting. Some of our data comparing laparoscopic sleeve versus endoscopic sleeve for weight loss have shown that while laparoscopic sleeve gastrectomy is more effective at 6 months, again, about half of excess weight loss is seen with a similar resolution of comorbidity. So in the case of the patient that we're presenting, not as important. He is pre-diabetic. He is not a smoker. There are, other high-risk comorbidities and a big abdominal wall reconstruction, pulmonary complications, other things that could potentially be optimized by actually doing an endoscopic procedure come into play. So I think that's why this is quite interesting. So as I mentioned, the plan for this patient, we do endoscopic sleeve, and then following the anticipated weight loss from the procedure, which hopefully will be mostly seen in about 6 months. I was just looking at what that would be for this patient in terms of the expected weight loss at 6 months, and it would be about 100 pounds. This guy's actually gained weight, unfortunately, since he came into our clinic. For him, he's uninsured. We were not able to get him linked in with a GLP-1 that was, either covered by our system or from some other avenue. And so this is why we're opting to perform the endoscopic sleeve. Obviously, this guy has had a pretty significant abdominal surgical history, and, who really knows what lies beneath the skin, I guess. And so, doing a surgical procedure in him would be very difficult, if at all feasible. And so, the considerations for the hernia operation, once we get him optimized from a weight standpoint are, first and foremost, how can we close the fascia? And so I think, having him drop that weight will help with this. given the fact that he's seen in our clinic, I don't think, Botox might necessarily be available. And so, then he would most certainly require a component separation. I guess from a practice standpoint, I learned in my time in North Carolina, it's typically, if we're, do the dissection and the anterior fascial defect's still larger than approximately 5 or 6 centimeters, so do an anterior perforator sparing release. And then, if that's not the case, and we feel like we could do a preperitoneal or retrorectus with tar, then, that would be our consideration. Use a synthetic mesh, and then plan to excise all that excess skin that I showed. But I think it's an interesting talking point. And, while there are barriers to getting this done in a timely fashion, depending on where you go, I think that this is a consideration that, we should at least have in our pocket if it's available at our institution. So, Bo, I know that you have written on the GLP-1 and bariatric surgery, so it'd be interesting to hear your perspective as well as that from other people.
Thank you, Sully, for the great presentation. Always on top as usual. I think my question goes along the lines of, we have all these different tools now in our war chest. How do you select a patient for bariatric surgery versus endoscopic revision, endoscopic sleeve versus GLPs or just lifestyle modifications? What is your algorithm? What is your thought process of how the patients flow down the pathway?
Yeah, I mean, I think first of all, I think, you look at a patient, whether they're symptomatic or not from their hernia, right? How much time do you have to get to the operating room? If it's not significantly impacting quality of life, and they have another comorbidity that could benefit from a bariatric procedure, either endoscopic sleeve or a laparoscopic sleeve or even bypass in the select patients, then that's something that I think would be more first line to go to. I think that the data, both from your group in Dallas and then from the group at UCSD, is quite impressive in terms of weight loss in a short amount of time using GLP-1s. And if these can get approved based on patient comorbidity, then that, to me, I think in my practice will be the first line of treatment. But in cases where patients are either having side effects from those medications, which we see not infrequently, or would like to opt for an endoscopic procedure for more sustained weight loss, then that's when I would start to think of this. So, but there's no answer. And I think for the endoscopic, data, there's really, really little data out there in terms of, kind of long-term for use of this purpose. But it's an exciting possibility.
Dr. Ayuso, thank you so much for your presentation and for your comments. Question for you: in a patient like this, where you've decided to go forward with the endoscopic sleeve, you commented that he's uninsured or underinsured.
Yeah.
How do you go about getting an endoscopic sleeve paid for a patient like this?
Yeah, that's a great question. I think, one worth talking about. Hopefully Dr. Lin can have a little bit more commentary, but we're seeing about a third of patients who come in our general minimally invasive surgery clinic get approved of this from an insurance standpoint. So patients with insurance, again, there's a separation here from the patient that I'm presenting. And then the rest are cash pay. And so there's a bundle payment for, all the services that are required around this sleeve or for an intragastric balloon. For this patient, luckily, there is hospital kind of support from a financial perspective to help this patient kind of get the best care that they can get. And so in this situation, our healthcare system, we're lucky enough, will help to bear most of the financial costs. But Dr. Lin, I'm not sure if you have any commentary or have had difficulty getting this type of stuff approved.
No, I mean, so and this applies to people who we've been able to do bariatric surgery for, as well as endoscopic procedures. The patients in your clinic typically are part of a federal health center where we it's a more of a population health strategy where we bear the cost of every aspect of their health. So that's actually a really nice kind of a little segment of healthcare where you can make an argument that this procedure, if it helps them lose weight, it will reduce their hernia complications, and it's all internal, so those benefits are realized, as opposed to in a traditional insurance system where GLP-1 denied, weight loss surgery denied. What's the next step, right? So this is certainly a unique patient situation, but if patients, at least in our institution, for patients who are paying out of pocket for an endoscopic weight loss procedure, it's far less than a sleeve gastrectomy or gastric bypass. So I think more of them are able to afford it, and I think the sticker shock is far less for an endoscopic sleeve.
And not that it's necessarily the right thing, but there are people around offering patients endoscopic sleeve or cash pay, that are kind of expediting the traditional bariatric process. We don't necessarily do that, for our patients because we want to hold them to the standard of care in our bariatric center. But I think that that's something that you're going to see more and more of as more gastroenterologists and in our case surgeons are performing this procedure is cutting corners. And so I think you've got to really understand and ask yourself, if you're trying to do that to achieve optimization for a patient, are you doing them a favor from an overall kind of standpoint? Is this the right patient that can have their lifestyle altered like this?
Right. Thank you both for your comments. There's a question in the chat that's directed at the panelists and also the presenters. So if you're of the camp that believes that you need to have prior optimization before proceeding with a definitive hernia repair, who really does that? It's a big responsibility. It's time consuming. It takes a lot of planning and preparation. Where does that responsibility lie? Is it on the hernia surgeon themselves, or do you have someone in your systems that you're able to help outsource some of that responsibility and work to get these patients as optimized as possible before surgery?
Dr. Lynn, you want to take that one?
Yeah, I think it's the hernia surgeon's responsibility to at least coordinate it. So I don't prescribe weight loss medications, but I know who does in our system, and I facilitate those appointments. I have the patient seeing me for regular follow-ups. You can pick a time. I do every 6 weeks, so they're alternating with me and a weight loss provider during that time period if they need other interventions. I feel like, if you just tell people come back when you've reach your goal weight, they're not likely to do it, and I think they feel kind of abandoned, and it's almost like you don't care if you tell them that. So I think it's the responsibility of the hernia surgeon.
And I think if we're treating this as a chronic disease, which, hernia is, having those regularly scheduled appointments. I know that's the practice with Dr. Lynn. That was the practice with Henneford and Augustine in Carolina, was to see, patients at a kind of regular interval. Because I think, when you deprive a patient of kind of hope for anything, even if that's a non-operative approach, then, that can take away from their rapport with you. But yeah, Dr. Lynn, I mean, he sets a standard with that and seeing patients back. But I know not everybody has the resources to do that.
Great, thank you both. Just to be on the devil's advocate side of this, just today in my inbox in General Surgery News was the article, optimization for hernias may have gone too far, experts suggest. I'm wondering if anybody on the panel has any comments about that. Do you really think that we've taken optimization too far? Are we delaying care that should be done earlier? Are we just playing it safe? Or are we just cherry picking the cases that we want to do?
Yeah, I'll comment on that. I think it's very similar to the smoking cessation discussion that Clayton and Mike Rosen had a couple of years ago. I think it's where we draw lines in the sand and become very dogmatic. It's probably, like most would agree, looking at that patient on their continuum of where are with their symptomatology, their barriers to weight loss care. And so I think when we say, well, you must reach this BMI, we're not doing the best we could. But the same token, if we say, well, I don't care if you lose that weight, I'll do your surgery tomorrow, so somewhere in the middle is probably the right answer.
I challenge everyone here and anyone that's listening. Optimization has kind of taken a few hits over the course of the last few years. A lot of population-based studies saying that it's not good or it's disenfranchising certain populations. The reality is that surveillance programs are lacking even more than optimization programs. And so no one really knows the real outcome when you operate on patients. So getting them to the operation isn't the finish line. That's the start of the race in some ways. And so you're preparing them for the race with optimization. Then you have to see how they actually do. And so long-term surveillance is the key. And so I really hope that over the course of the next 5 years, we can work on really understanding long-term outcomes of patients who are getting operations, whether they're optimized or not, and know what the true indications for surgery are.
Thank you all for your excellent comments. With that, we better get moving on to our third case.
Third case will be presented by Dr. Artem and his group. I apologize again. I don't want to mess up your last name. Dr. Artem finished his residency at Ascension St. Agnes Healthcare and then proceeded to do his fellowship with Dr. Yuri Novisky at Columbia. He is now a professor at Stony Brook, where I did my medical school.
Thank you very much. I'm going to go ahead and introduce Dr. Spivak, who is one of our MIS fellows. After graduating from Brown residency, he actually obtained a surgical critical care fellowship at University of Maryland Shock Trauma. And he joined our fellowship to supplement his training with additional minimal invasive skills and abdominal wall reconstruction. He will be presenting a case which we did together a couple of months ago of robotic external oblique release.
Thank you. Sorry for my voice. I got a little gift virus from Stony Brook this week. So overall for our case, the case we'll be discussing is a 70-year-old male with a BMI of 18, with pretty significant comorbidities, including COPD and CAD with stents on DAPT, who had a colectomy and then has been complicated by multiple incisional hernia repairs with a couple attempts at primary repair first, and then his last attempt was an open reef stopo where they placed a 10 by 15 centimeter progrib mesh, and then he presented to us with a 5 centimeter mid-epigastric recurrence. So our question was, do we dive back in or is there another approach? Just briefly, we'll discuss the onlay repair, review data, go over our operative technique, and review the case, that patient's case video. The onlay repair, I'm sure as everyone here knows, developed in 1970 by Jean-Paul Chevrel, the placement of the mesh above the anterior fascia. However, open onlays repair start to fall out of favor, secondary to high rates of dermal flap necrosis, secondary to the large skin flaps and myocutaneous flaps that were made, usually due to taking, as you can see here in the picture, the zone 1 perforators, which led to a higher rate of flap malperfusion and mesh infection and complications. In 2002, Dr. Dumanian published a study to review classic repair versus repair with preservation of those periumbilical perforators. And they had no difference between the patients, but showed a statistically significant difference in postoperative wound complication noted between the two groups. The standard non-sparing had about a 20%, which is very high, wound complications versus 2% with those that spared the perforators. And they added on that any simultaneous intra-abdominal access or procedure would increase the prevalence of wound complication as expected. The original anterior component separation provided about 10 centimeters of medial advancement, and then perforator sparing techniques that were developed endoscopically, which I'll show a picture of later. Here you can see a picture on the original one where the external oblique was mobilized, and then that myocutaneous or myofascial flap by mobilizing the posterior sheath as well to bring everything medially about 10 centimeters. And then Dr. Malcher in 2023 published his paper about robotic techniques for this. So when comparing endoscopic versus open component separation, Dr. Kamali and his colleagues, showed that the wound complication rates, as you can see here, were much less with MIS techniques, 20.6% versus 34.6%. And infections, skin necrosis, and hematoma and seroma were also much less. The original kind of description of endoscopic approach is seen here, where incisions were made bilaterally over the where you would divide to get under the external oblique, and then using balloon dissection separate it up, as you can see here. So for our case, we placed 3 millimeter, 8 millimeter ports laterally and then redocked on the other side. First is reduction of the hernia and lysis of adhesions just to the contralateral posterior rectus sheath. And then the incision was made above the contralateral side, but we make sure to stay above the fascia, but just under the hernia sac, and develop the lipocutaneous flap over the anterior fascia without damaging the anterior fascia. We then carry out the dissection to the lateral edge. That'll give us a view to incise the external oblique 1 to 2 centimeters lateral to the rectus border, and then continue that division of the external oblique aponeurosis from the costal margin down to the inguinal ligament, or ASIS. And then usually you'll have to redock on the contralateral side through the myocutaneous flap and do this similar dissection to develop the contralateral flap, close the midline fascia and defect, place our mesh, and then drains and fibrin seals being applied here. So just to review our case, it's a 70-year-old male with multiple cardiac comorbidities and multiple intra-abdominal surgeries, primary hernia repair, and progrip mesh placement with an open reeve stopa. You can see the CT scan here with the recurrence in the mid-epigastric area with containing bowel. And then this is his pre-op picture. That's our port docking there. And then you can see the hernia defect here. So we lyse the adhesions. And then, as you'll see, it's important to really avoid entering the anterectus space and really stay between the sac and the anterior fascia, which really gets you in the right plane, which here you can see it's a pretty good picture of it. You can see the old suture there from his prior repairs. So then once we develop the lipocutaneous flap, we develop enough space to view where we're going to divide the external oblique from up by the costal margin down to the inguinal ligament. And here we're measuring it out. Here we dissected about 15 centimeters lateral to the defect and identified the lateral border of the rectus, and then incised the external oblique right here. This patient had about a 9 centimeter long defect with his intact retrorectus mesh in that spot. So again, making another posterior approach very difficult if we had attempted it. Here's a good view of just using the robot, really developing that flap, maintaining a bloodless plane. And then here, developing the flap further down, and then using the laparoscopic ligature there as well, and then redocking on the other side. Similarly, on the other side, once the flap's developed, we identify the external oblique aponeurosis inferiorly, and again, carry the incision really importantly to the costal margin, and then dissect out that inner oblique space down to a couple centimeters above the inguinal ligament. You can see the costal margins there and the ribs kind of tenting everything up. And then here we're dividing the external oblique and developing that space. And then here closing the midline defect with our #1 non-absorbable proline and measuring the defect. And here we were able to fit in a 25 by 25 centimeter macroporous polypropylene mesh. And then you'll see we secured it, and then we put in fibrin sealant as well. So he recovered well, and he had some aseptic partial thickness skin necrosis. The picture on the left is post-op day 1, and then on the right is a week out. And the marking actually was from after we took the picture on the left, so you can see that it didn't spread, and you can see the spoiler alert of the Pravina wound back there. So we managed it with a Prevena-Vac to improve lymphatic drainage and microcirculation. So really the learning point from this case and our approach, this patient who had a pretty significant cardiac comorbidities and then pretty much obliterated retrorectus area, the decision was whether to go back in and attack this in a plane that had already been operated in multiple times and had prior recurrence with previous progrip mesh there, or if he was a better candidate for a robotic external oblique release. So in our conclusion, the robotic external oblique release is a viable option after multiple failed repairs, which in him would have been a XLAP, redo retrorectus, and redo TAR, which probably would have had significant morbidity. But with these patients, the selection is crucial. He's a low BMI, thin, and had quit smoking. He was not on home oxygen. So we were able to avoid most of the intra-abdominal adhesions. His weren't horrible, but you can try and avoid the full completion of lysis of adhesions. The downsides is the onlay mesh and then not sparing our pillar umbilical perforators, but with the robotic approach, you really aren't leaving a large wound that in the midline that's closed. And then the skin ischemia, just as a learning point, can be managed with non-pressure wound therapy, or the VAC, the Prevena-Vac, which we've had good success with. And we'll take any questions.
Thank you, Dr. Spivak. Thank you, Dr. Artem. An amazing, amazing technical video. I think I am saying what everybody else in the chat is saying. Great surgical technique, beautiful video, amazed. I think my first question comes down to, I don't want to sound like the algorithm guy, how do you select a patient for this approach? And I know if we question the panel across the board, previous retrorectus repair, recurrent hernias is the albatross for all of us. We'll probably have a different answer for this case. So what is your algorithm, and which patients fit this approach much better? Does this approach apply to much better? That's what I'm trying to say.
Yeah, thank you. Thanks, Colin, very much for presenting that. Sorry about your voice. So, we did only one similar case in fellowship, and actually we were trying to find somebody who will be an appropriate candidate for that. And I think the key is really to look for folks who you would anticipate really hostile abdomen and those who otherwise have very thin sub-Q. And, this patient pretty much fit that indications. And, the reason why he got the recurrence, I think it's because the original mesh was just something about 10 by 15 in retrorectus position. So, definitely we didn't want to go back in him, old frail guy, and do any kind of retrorectus dissection. I mean, and also it's a superior defect, right? So it would be really difficult to medialize it without external oblique release. And another option would be probably just to do some sort of bridge, but we decided to do nice repair and bring his midline together. We did use drains, and the drains stay for about 2 weeks in him. Actually want to do a shout out to Vahak, whose idea was actually to put the Prevena on, because I called him when I saw this guy on post-op day 1, and he has the skin duskiness. I did lose my cool a little bit on that, and so we decided to put Prevena, and I'm still in touch with him. Everything has settled. He still has some dyspigmentation of that area, but it all completely healed up, and he recovered really well. It was about 2 months ago now.
I didn't know that I had given you advice on that, but that's awesome. I was like, wow, his philosophy on Prevena is similar to mine. I like it.
Dr. Queen Nunez asks about what is the probable cause of recurrence in this patient?
Yeah, so I think they just undersized the mesh, because he recurred exactly above the mesh. Where the mesh was integrated well, it was very solid repair with muscles together, but he just recurred immediately above the mesh, superiorly.
Dr. Mazzola asks, do you have any thoughts on patients potentially filling the mesh postoperatively, given such the mesh size in the sub-Q space, and particularly very thin patients, which are particularly in very thin patients, which are the best candidates for this?
Yeah, so he doesn't complain. He's a VA patient, I think, pretty stoic. But frankly, after this external oblique, his sensation of abdominal wall is pretty diminished, I think. So in general, this area is kind of slightly anesthetized and really not tender at all, actually. So well, at least he didn't complain of any tenderness. However, the patient whom we did with Yuri, he was very much uncomfortable, and it was really painful to take care of him afterwards. He was not a veteran.
I'll throw a
You can
question out
add
there.
that to your algorithm. They must be veterans.
It must be veterans. Question for you, and sorry if I missed it, but what would you recommend for drain management for a robotic onlay repair?
Yeah, we keep this drain until it really dusts. So, I do some scolas as well. And although we don't place mesh, I don't typically try to, put the mesh for scolas. I got burned a couple of times when I removed the drain because patient was, really begging me to get it out, and we took it too early. And then patient developed, of course, a really large seroma. We had to put IR drain. So for this guy, we kept it for about actually 2 weeks, and with binder day and night just to really squeeze it out, whatever fluid is building up. And it's just me, but I really like to maintain those drain dressings, especially for any onlays, as a central line. So we use Tegaderm IV with chlorhexidine jelly, and I use some mestisol, benzoin, and just really maintain this dressing, super sterile, as if the patient has like a PICC line, because I just kind of feel that it's potential entry for infection.
All good questions so far. I'll take a poll of the panelists. In the patients with a recurrence retrorectus repair, I'm sure we're going to get variable answers here. This is a challenging case, and this is a great video. What technique will you guys choose in a patient like this based on what you've seen thus far? Vahan?
I like pre-peritoneal. And then if I have to, I'll recruit that old mesh and or the rectus sheath selectively. So I like extended pre-peritoneal dissections. I'll get a lot of posterior flap. I'll have a big underlay space, or I'm sorry, sublay space developed. You can recruit falciform for these upper hernias. So that's my preference. But I think, again, a really amazing technical accomplishment here by Dr. Shmelev.
I see Dr. Lin said a redo tar. That's a man with a lot of heart.
Just trying to be different. No, I don't like redo pre-peritoneal because I just all those holes at the end. I think trying to redo the tar and you get some of that you get some of that kind of scar on the mesh that you can use attached to your posterior sheath to try and keep some type of posterior layer intact. But no, some of that is just to be contrarian.
I'll say for a multiply comorbid person, certainly I still think you could consider doing an IPOM plus for somebody like this to minimize their risk of complications and minimize their time under anesthesia.
A classic example of how we're all different and we all see things differently. There's always challenging cases, but the video is amazing, the cure is amazing, and you're making Stony Brook proud. Thank you, Dr. Harton.
Excellent.
We'll move on to the next presentation.
All right, we'll move on to our last one. This is a presentation of a repair of a midline hernia and bilateral semilunar line disruption. This is going to be shared with us with Jenya Zilberman-Rudenko, coming to us from Oregon Health and Science University.
Hi, thank you so much for having me here. I'm a fifth-year resident at the Oregon Health and Science University. I'm originally from Estonia, did my undergrad at Berkeley, and medical school and PhD also at Oregon Health and Science University. We did this case with Dr. Sabrina Brexel, who is actually also a graduate of OHSU, so a little mentorship going on here. This is an interesting case with a 71-year-old lady with a BMI of 27, former smoker that quit back in the 80s. She's non-diabetic, but she has a very extensive surgical history including open cholecystectomy in the 80s, 2 ventral hernia repairs open with mesh back in the 90s. Then some mystically described in her notes intracutaneous fistula and sepsis due to mesh infection. She required mesh removal and open abdominal exploration from that and a wound vac closure for over 6 months. Then she recurred back in September of 2022 and had an open recurrent ventral hernia repair at that time. The note that we have available is very confusing. They mention sublay and retrorectus, but they don't really talk about the appropriate layers, don't explicitly describe the component separation, but specifically discuss how they left the lap pad in the belly and then had to make a hole in their mesh and closed it with a Vitralex patch at the end. So interesting. So this is her CT, and you can see there's some, in the green, semilunar defects bilaterally with the colon stuck in there, basically absent rectuses, except for deeper in the pelvis, where she has an inferior recurrence from her prior meshes repairs. So here in blue, here's the rectus sheaths, the rectus muscles, and it's going back. So pretty complicated. So what do you do with this? You got to know your anatomy. This is a shout out to Dr. Novinsky and his Atlas, aka Bible for us. You have to really know what you're doing here. It is possible that they got an issue there because she had a denervated erectus on the right and they didn't get their proper layers. We don't know what they were dealing with back in 2022, but it kind of looks like maybe they did some sort of anterior release and messed up the linea alba, linea seminaris, and then had this dehiscence here. Or maybe they had a posterior sheath dehiscence. It's really unclear, but definitely didn't do an appropriate repair, whatever they were trying to do. So what do you do here? She has 2 hernias, or basically complex multiplex hernia with ventral hernia and these bilateral semilunar hernias. And she is very symptomatic from that. She continues to be pretty active, but cannot be to the activity that she wants. So really watchful waiting is not appropriate for her. Open repair, she's definitely against that. And, you know, everybody knows this is going to be a giant mess. So can you try to do this MIS? There's a really nice paper that is actually talks about robo-TARS, and then some of the aspects of this paper were definitely used here. So our goal was to really develop this plane. We knew we're not going to have any posterior sheath most likely here, but hopefully we're going to have some layers here that we could recruit to get a coverage and place a very big mesh. That was the idea. So how do you get into this belly? For me, as I'm going to be getting into practice next year, should we go for Palmer's point? Should we go varus, opt-to-view, cut down? So what we ended up doing here is, since the whole belly is really involved, we went to the Palmer's point with the varus and we did 2 passes with the varus, got high pressures and stopped. And then we did a cut down, really grasping the fascia and opening, and then putting a robotic trocar in there and getting in the camera. I tried to look at the literature actually to see what is quoted as the safest entry into the belly. And I know everybody on the panel probably has their favorite and stories to go with it. But once we got in there with the camera, we started lysis of adhesion with the camera itself to basically create some space to be able to add additional trocars. And then once we got the trocars, we were able to dock the robot and start basically kind of a retrograde lysis of adhesions. Then we're starting to take off the amentum and the colon off of this peritonealized prior mesh. This is the ventral hernia inferiorly that I talked about that had small bowel. We reduced that. This is the semilunar larger defect where that had colon contained in it that we reduced. Then this is all reduced and cleaned up. Then we redock the robot. We get rid of this Ventralex patch that is just silly to keep that in. And then we'll continue working on just recruiting whatever we can find, kind of like we discussed at the prior panel discussion. Just the peritonealized prior mesh, any layers of whatever prior posterior rectus sheath lamella that is there, scar, anything you have. Here's more of a virgin territory. You can see a rectus muscle that was preserved in the CT, popping in the view, and we run with this layer. And basically, once we get this layer, we get more layers lower, we start working in the next steps on our bottom-up TAR. So here, we're starting to develop our preperitoneal cave, getting into that TAR plane, making sure we preserve whatever's left of the semilunar line on this side. And obviously that was a really thin layer because we're below arcuate line. Here we continue to recruit whatever we can to get that coverage for a future mesh. And then once we've gotten laterally enough, we close the arcuate, we close the semilunaris defect here. This is the smaller defect that was on the left side. And then we secure our mesh that is rolled up and has a thing. And then we reduct the robot. We continue to recruit more tissue. You can see rectus muscle on this side. And we basically repeat the steps. This is a more complicated side. This one has the bigger semilunaris defect with the colon that was sitting in there, irritating all this. So lots and lots of scar. So here you can see above is a semilunaris defect, that intermuscular space that had the colon sitting. And here we're dissecting off peritoneum and pretransversalis tissue. So I have them outlined here. Oh. I'm not sure why my video stopped. All right. Okay. Then to really collapse this intermuscular space, we close this in layers, kind of going from inside out. This also helps to redistribute the weight and the retraction of these muscles here. When we talked to some of the colleagues that had to encounter this, some people actually do this first. They close the semilunaris defect before starting to do any types of preperitoneal dissection. We, however, encountered a lot of adhesions here, so we were not able to do that. But once we were able to close this, it really helped us to expose that lateral component so we could really carry out our TAR all the way to laterally to get nice coverage of our new mesh. As you can see, lots of scar, some bare muscle, just a big mess. This is the ventral hernia that we're also closing with a V-lock here, just running V-lock. I'm not sure why it keeps getting stuck, you guys. Oh, great. Sorry. All right. And now we're going to take all of the things that we recruited, all the peritonealized tissue, and recreate our new posterior sheath. Once that is done and we covered all of the holes that are above 5 millimeters, we'll roll out our mesh. And then we cover everything with TCL liberally, so nothing shifts, and discipline. So the patient did pretty well after post-op. She actually was able to discharge from post-op day 1, doing really well, barely taking any opioids. We're seeing her 1 week post-op, and she was doing well and had no signs of seroma. She now traveled back to Colorado, and we're going to see her in a month. So in conclusion, recurrent hernias, this can be a big mess, and especially when you have a semilunar disruption, when people had multiple hernia repairs and possibly disrupted layers and were not able to find appropriate anatomy. So, you know, you really need to understand that anatomy to and be able to reconstruct a semilunar line. When you're completely stuck and cannot see anything beyond the scar, it is a good idea to find the layers that are identifiable. So for instance, here we were able to go down into the pelvis in a space of red CS and really find the layers that are identifiable and go up from there with our bottoms up TAR. Obviously, you need to get a really wide mesh overlap. I think the reason that she recurred after her most recent modern surgery is because they didn't get the inferior overlap for their mesh, because you could see the recurrence was right below the mesh again. So really dissecting down to space of Bucras and space of Retzius to get that overlap. And then, you know, if you need to, you go up to the diaphragm as well. And that's all I had.
Jenya, thank you so much. That was a brilliant presentation, and really what a fine example of how complicated abdominal wall anatomy gets after so many failed repairs and so many mistaken attempts at component separations. I mean, these really become really complicated things, and I certainly give you kudos as well for even having the patience to decide to attack that minimally invasively. I think deserves applause. Which mesh did you guys decide to use for that repair?
We use the polypropylene macroporous mesh, just biotin mesh. She got a 28 by 28 in here. Yeah.
Great. Right. Any questions from the audience or from the other panelists?
Yeah, really cool case. How do you set expectations for what a good outcome looks like for this person? Do you tell them they're not going to have a bulge, they're not going to have a recurrence? Because obviously those muscle layers aren't going to work the same way. How do you set their expectations beforehand?
We basically discussed with her that her recurrence rate is really high. Her functional status in terms of what she was trying to achieve is to be able to be more active. She wanted to get back into running, and then those bulges in the colon stuck in the side was not helping her. So, and she also just basically wanted to have normal bowel movements. So she was not obstructed, but she was definitely struggling. So those kind of were her goals. And she has gone through the rodeo, so to speak, 5 times now. So she knew that this is going to be her final shot to really give it give it all and get nice big coverage internally. But it is possible that she will recur and she will never have a 6-pack. She will never have a beach body or the strength that she had back in the 90s. So she was fine with that.
Yeah, I do think that's a really important point to bring up, just because, what is the patient's goals, right? And you sounds like you guys obviously had a really good understanding of like what her goals were, because she's still probably going to bulge, right? She had semilunar line injury, you fixed the muscle, but you can't fix the neurovascular bundles.
Right.
And I think that's really the big key here, right? Is we often measure our success in recurrence rates and things like that. But the reality is if we're improving people's quality of life, then we're probably doing the right thing. So it's a really awesome case. Thanks for presenting it.
I remember piggyback off that amazing case. I think I was having palpitations just watching that. That was a tough case. Question, we already know that, neurovascularly that area is kind of not in great shape. What is the role of maybe heavyweight mesh in a case like this? How do we discuss mesh selection in cases like this?
I honestly couldn't find very definitive papers in terms of how do you address semilunar line disruption. I found a couple of case reports where people were doing basically sandwich meshes with anterior component and inferior, more like for very big Spigelians types of things, or people who had nephrectomies in the past. Majority of the case studies that I found were using macroporous, because you want to really integrate the mesh in there and get a permanent mesh for sure, and really have a big wide overlap. That kind of seemed to be the biggest thing that was preached, which makes sense to me.
I want to acknowledge Jenya's hard work here. She's a chief resident, but she's answering fellowship and even the faculty level questions. Dr. Drexel couldn't be here, but I'm sort of helping out as like the other Portland surgeon here. Amazing work. I think for many of us watching, we're like, wow, I would have converted to open. I would have converted to open. But clearly it shows the benefits for the patient being able to get discharged the next day and do so well. So major props. Just querying the people that are on the panel. Oh, who would attack this robotic and who would attack this open? I know I would do this open and I would probably use heavyweight mesh as Bola alluded to.
Open heavyweight mesh on my end too.
Same with me. Any off midline hernia, lateral hernia, posterior hernia, I typically would use heavyweight mesh.
One thing about the CT scan that I'm seeing here, there's a there might like I've seen a few of these patients who come, they look like the Mickey Mouse hernia and it looks like a semilunar line. And when I've gone in, it almost looks like it was actually a posterior disruption, and then it mushrooms out and bulges out the rectus, almost looking like bilateral semilunar line injuries. I can't totally tell here. It almost looks like a partial disruption of semilunar. And so for these, when I go and open and I reduce the viscera, I'll just bridge the posterior and then assess if there's like a true defect. When you were closing that semilunar line, were you doing it anterior to the rectus or were you doing it on the posterior side?
Posterior to the rectus or posterior side. We started from posterior and then closer. We did it in layers.
Okay, because it looked like you were almost working anterior to the rectus and closing it, but I guess maybe I was just misinterpreting it. Very interesting.
Excellent case, Jenya. Thank you so much for preparing that and sharing that with us tonight.
Absolutely.
Well, that's our last case. Are there any other questions for the panelists or for any of the speakers from the audience or from anyone? There's a question. Did you perform a pre-op 3D reconstructive CT scan? Any specific software? Amazing video.
We did not perform a 3D scan. Yeah, and you're actually seeing a video from somebody's phone who took a video of the scan and it was sent to us. Yeah.
Great. Thank you, Jenya.
Mhm.
I just want to thank everyone for joining us this evening, for your incredible comments, for the incredible presentations. Thank you to each one of the presenters. Really excellent job. I think there's so much value in talking about these things and learning from each other, and want to thank everyone for your participation.
Thank you guys and have a great rest of your day.